Morning, sir and ma'am. Shall I start? My case, Mr. X, is a 15-year-old child who is second born out of second-degree consanguineous marriage, studying 9th standard, who is coming from Vellore, and his informant is mother, and her reliability is good. And her mother is staff nurse by occupation, and now he is admitted for renal transplantation, and he is now post-renal transplant 22 days. I would like to start history from his onset of illness. Actually, his antenatal period was uneventful, and antenatal scan was normal. Both anomaly scan was normal, and the child was delivered by assisted vaginal delivery, and indication for the assisted vaginal delivery is fetal bradycardia and no history of NICU admission. At 2 months of age, child was diagnosed to have lactose intolerance, for which breastfeed was stopped, and the child was started on lactose-free formula feed and rice porridge.
Kitika, be a little slow.
Okay, sir. At 7 months of age, child had high-grade fever and diagnosed to have febrile UTI, for which child was evaluated and found to have enlarged kidneys with lower urinary tract obstruction. Probably child have hydronephrosis with PUV, and child was treated with antibiotics for this episode of UTI and started on Septron prophylaxis. And mother remembers that serum creatinine at this time was 0.8. At 9 months of age, child again had second episode of UTI, and this also treated with IV antibiotics. And after this episode got treated, child was extensively evaluated, MCU done, which showed bilateral reflex. And the child was started on tablet tropan, and the serum creatinine at this time was 1. At 10 months of age, child underwent one urological procedure, probably cystoscopic valve fulguration. At 2010, at around 2 years of age, child underwent surgery, that is right loop ureterostomy, and child was on this for 2 years. And child was on regular follow-up for every 3 months, once in every 3 months. At April 2012, when child was 4 years of age, child underwent right ureterostomy closure along with right ureteronephrectomy. The reason for this was not known to the mother, probably because of right non-functioning kidney. At this time, mother remembers that creat was 0.1. At 2018, at 9 years of age, child again underwent MCU, and it showed persistent left-sided reflex, and creat at this time was 1.8. And child was on tablet tropan, started on tropan, soda bicarb, calcium and iron supplements. Since 2020, the child was on regular follow-up, and the last creat was 3 as remembered by mother. Then child lost to follow-up during COVID times. There is no history of difficulty in micturition or staining or double voiding or feeling of incomplete emptying of bladder. But child has nocturnal enuresis till 9 years of age. No history of increased urgency or frequency. At October 2023, child presented with dyspnea, no history of reduced urine output. On evaluation, child found to have serum creat of 30 and severe anemia, and child was started on hemodialysis through right IJV non-cuff non-tunnel catheter, and the duration of dialysis was only 1 hour, and child was given 1 unit PRBC. Then child underwent multiple sessions of hemodialysis. After 1 week, his non-cuffed non-tunnel catheter changed to cuffed tunnel catheter, and child got discharged with the advice of 3/7 maintenance surgery and with 4 antihypertensives, namely Nicardia, clonidine, minipress, and labetalol. Then after 2 days of discharge, again child admitted with breathlessness, and his mother told that he had pulmonary edema, and he underwent another 1 sessions of hemodialysis. And he also diagnosed to have LRTA, for which he was treated with antibiotic. Then after 1 week of discharge with this, from this episode, child again admitted with fever and cough, suspected catheter-related bloodstream infection, and he was started on antibiotics. But in spite of antibiotics, child continues to have fever, hence suspected fungal infection of that catheter, and he was given antifungal, probably antifungal, because that infusion was given over 4 hours, but all blood culture showed negative for both bacterial and fungal. Till this, the child was treated at pediatric nephrology unit, and then the child was transferred to adult nephrology unit as he completed 14 years. In here, the child was worked up for live related renal transplant with father as donor. Meanwhile, he also registered for deceased donor transplantation on 14/12/23. There is no frequent interdialytic complication. His interdialytic weight gain is 1 kg. His residual urine output is 400 ml per day. And he is on 3/7 maintenance HD and his dry weight is 37 kg. And he was vaccinated up to age. His family history, no family history of renal disease. And his elder sibling is 19 years and he is healthy. After 2 weeks of registration, he had a call for his deceased donor renal transplantation. And the cross match was said to be negative. And the donor was 14-year-old. The cause of death was RTA, and the serum creatinine of the donor was not known to the mother, and the blood group of the donor was O positive. And cold ischemia time and warm ischemia time was not known to the mother. Interim complications was also not known to the mother. But mother told that the child was given special injection that was started before transplant along with pre-medication. Probably the child may get graflon induction. Immediately after post-transplantation, the child was extubated and shifted to post-transplant ICU. In the immediate post-transplant period, the child underwent 1 session of hemodialysis in view of hyperkalemia. And also child has uncontrolled hypertension, for which the child was started on labetalol and NTG infusion. And the Doppler which done on the day of surgery showed normal. The child approximately had urine output of around 800 ml per day and around 2 liters per day on the day 1 of surgery, POD1. On day 2 also, child underwent another 1 session of hemodialysis for hyperkalemia. Then the child has gradual rise in creatinine only. The child creatinine on day 6 was 5.5. On POD7, the child underwent the 3rd session of hemodialysis for 5 hours because of his weight gain. As the child dry weight is 37 kg, at day 7 the child had a weight of around 47 kg, for which he underwent 5 hours of hemodialysis. On POD8, his creat is 3.6. Then he had gradual fall in creatinine. On POD10, his creat is 0.2. Then POD12, the child underwent renal biopsy, but the mother was not aware of the report of that biopsy, but she told that he was not given any special treatment or any special form of dialysis. Now his current creatinine is 0.8 and his best creatinine is 0.8, and now his urine output is around 2.5 to 5 liters per day. And currently the child is on triple immunosuppression, tablet MM of 750 mg BD and capsule Tacro 1 mg 3.5 in the morning and 4 mg in the evening, and tablet Predni 10 mg, tablet Predni 20 mg. And the child was started on tablet some drugs, probably Valgan and Septron prophylaxis. Summary, the child is a 15-year-old who had recurrent UTI in the infancy and found to have PUV, for which he underwent urological procedure and right ureteronephrectomy, and MCU showed reflux, probably secondary VUR. And the child had slowly progressive renal failure and the child developed ESRD 3 years back and underwent deceased donor renal transplantation 3 weeks back, had delayed graft function, and he was supported with hemodialysis.
Okay. 14-year?
Yes, ma'am. 14-year-old child, ma'am.
Okay. So he has got a very long history starting from his infancy. And his main problem is his cacot.
Yes, ma'am.
Probably a posterior urethral valve from the history. So it was actually corrected at the age of 11 months. Yes. Why he developed a progression of CKD? What do you think is the reason for that?
2 reasons, ma'am. One child with cacot can have some other cacot, like renal dysplasia. Another one is because of this VUR, child have increased pressure in the intrauterine itself. That increased pelvic pressure will affect that nephrogenesis, ma'am.
Okay. Then, what are the other cacots which can associated with PUV? Associations of?
There can be VUR.
Is it a primary VUR or a secondary VUR?
Can have primary VUR also, ma'am. But mostly
how do you know that this primary or secondary? How do you differentiate VUR?
By cystoscopy, we can visualize the location of ureter. If it is laterally placed and the opening of the ureter is very platulous, it can be primary VUR, ma'am. In secondary VUR, the location of ureter is normal. That is in the angle of the trigone, ma'am.
Ultrasound wise?
Ultrasound wise, in secondary VUR, the bladder wall will be thickened and there will be trabeculations and diverticulum. But in primary VUR, this won't be there, ma'am.
Okay. Then what about the hydronephrosis? Will there be any asymmetry in hydronephrosis in primary?
In primary VUR, there will be asymmetry, but in secondary VUR, there won't be any asymmetry, ma'am.
Why the child received tropan for a long time? What is tropan?
Tropan is oxybutynin, ma'am.
Why?
Actually, it is anticholinergics.
Why it is given? How does it help in the
It will
course of
increase the
disease?
bladder capacity, ma'am. It will increase the bladder compliance, actually.
So what is what is gallbladder syndrome?
Actually, valve bladder syndrome, the child with the posterior urethral valve can have 3 types of bladder, ma'am. One can be hyperreflexia, detrusor hyperreflexia, and another one is non-compliant bladder, and another one is myogenic failure, ma'am. In this,
What will be the bladder neck in patients with posterior urethral valve?
bladder neck will be hypertrophied, ma'am.
Okay. So how does this oxybutynin help? Why do you give this?
It will cause detrusor muscle relaxation and it will increase the compliance of the bladder, ma'am.
Increase the compliance. Okay. Then what will you do for, what are the other, you said the detrusor overactivity will be there, bladder neck obstruction will be there, and all these can cause a high pressure inside the bladder. So that is why you are giving all this. So what are the other measures you will try to reduce the pressure in the bladder? Because increased pressure in the bladder is responsible for the damage to the upper moiety. So
We can do
he had undergone this ureterostomy, cutaneous ureterostomy.
ma'am. Right side alone,
why it
ma'am.
was done?
in spite of the PUV fulguration, if the child has worsening of creatinine or if the child have continuous damage to the upper tract, we can do this upper tract salvage procedure, ma'am.
What is the creatinine limits which will tell you that's going to have a bad prognosis?
At 1 year, if the creat is more than 1, child with PUV will have poor prognosis,
Poor
ma'am.
prognosis. Okay. So how does it help the diversion procedure? How long you will keep the diversion procedure? How is it going to help? So what is a definite indication for ureterostomy?
If the creat is persistently rising even after fulguration,
Okay. What is its advantage? It will rapidly reduce the upper tract pressure. So that is it. Rapid reduction. But still, despite all your measures, child will develop ESRD very often in PUV.
yes, ma'am.
So why do you do all these things? Anyway, child is going to develop ESRD.
By doing this, we can prolong the time to.
What is the advantage of prolonging the onset of end-stage kidney disease in a
In
child like this?
The growth retardation will be prevented, ma'am. If the child go into ESRD early, there will be some growth retardation. There is cognitive impairment will be there. We can prevent that.
But
ma'am.
there will be ESRD. CKD will be there, that will be progressing to ESRD. But then you can, by delaying the onset of ESRD, the dialysis and transplant will be more easier rather than doing it in a child. That is a major advantage. How do you manage the bladder neck obstruction? What is the reason for bladder neck obstruction PUV?
Because of this obstruction, there will be hypertrophy of this
yes, very
detrusor, ma'am. That will cause obstruction.
So how
we
do
can give.
okay, good.
We can
What is the management?
We can give alpha blockers, ma'am.
Alpha blockers.
Or
Anything
we
else?
can do CIC, or we can do vesicostomy.
Alpha blockers can be given. Bladder neck incision may be done. Then you may also try botulinum toxin as a medical management. Vesicostomy or ureterostomy is done mainly to decompress the bladder and relieve the upper tract. Okay. Any other measures you will give? Medical management, postnatal. You have fulgurated bladder. You have done the upper tract decompression. You have continuing to give tropan. What else you will try?
We can give soda bicarb.
Okay. How is soda bicarb is going to help this boy?
Acidosis will prevent the progression of CKD, ma'am.
What are the 3 adverse effects of acidosis?
Child can develop MBD, ma'am. Poor growth.
What about muscle?
Muscle weakness will be there, ma'am.
Muscle, reduction in the muscle mass.
Muscle mass.
Okay. So you can ask.
So how will you replace bicarb for such a child?
For pediatrics, 1 to 2 milliequivalents per kg per day we can give, sir. 1000 mg contain 11.5 milliequivalents.
Of soda bicarb.
Soda bicarb. 1000 mg of soda bicarb will contain 11.5 milliequivalent. So,
Okay. What is the type of acidosis in CKD?
it is high anion gap metabolic acidosis, sir.
At all levels of GFR? it is
Initially, up to stage 3, it is normal anion gap metabolic acidosis. At stage 4 and 5, it is high anion gap metabolic acidosis.
Okay. What is Mitrofanoff's procedure?
Metrofenov is, it is done in the, it is, in this, the appendix is used as a conduit for continuous intermittent catheterization, ma'am. Can be done in case of VU or like that. In this, we can do the Metrofenov procedure.
So what is the advantage of this procedure compared to a ureterostomy?
Advantage of Metrofenov.
Okay. What is bladder bowel dysfunction?
Bladder bowel dysfunction is defined as it's a syndrome of lower urinary tract. It's lower urinary tract symptoms along with bowel dysfunctions like constipation or encopresis, and this is usually associated with VUR, ma'am.
So what would you advise in such children?
If we find a child with bowel and bladder dysfunction, first we have to treat constipation. For this lower urinary tract symptoms, we have to advise the child for timed voiding. Before going to bed, the child should be told to void.
Okay.
What are the procedures you can do intrauterine to correct the PUV?
We can do intrauterine vesicostomy, ma'am.
How do you know whether this procedure or intervention, it is a high-risk procedure, how do you know that this procedure is going to help the child? What all parameters?
Actually, there are, if the fetal urine sodium is less than 100 and chlorine is less than 90, and another 2 parameters are there, ma'am. If it is fitting,
what are the other 2 parameters? That's very important. Osmolality.
Yes, osmolality less than 280 and
200.
200 and beta 2 microglobulin less than 6. If it is fixing, we can do that procedure and child will have good prognosis. Otherwise, child will already going for irreversible damage.
Okay. What is the significance of this beta 2 microglobulin estimation in the urine?
No idea.
It indicates a glomerular damage. So again, that is, if it is high, the reversibility is going to be less for this risky procedure. So this child has a bladder dysfunction, PUV, and all those problems. And when will you do? What is the indication for augmentation cystoplasty in this child? So this is a real problem. You are going to transplant this child.
If the child had low compliance bladder, that time we can do augmentation cystoplasty using ileum, or we can do augmentation cystoplasty using one-side ureter, ma'am.
What is the disadvantage of using ileum for augmentation?
It can go in for malignant transformation, one thing, and another one is reabsorption of this uremic toxins again will happen, ma'am.
Anything else? Okay. At what age they attain continence, daytime continence, and what age the child?
Child attain daytime continence by 3 years of age and nighttime continence by 5 years of age. But for nighttime continence, we can wait up to 7 years, ma'am.
7 years. Suppose if a child is coming to you with a nocturnal enuresis in your practice, so what all things you will say? How do you counsel the parents? When will you do investigations in detail?
If the child is more than 7 years, we can do investigation, ma'am. First, we have to rule out. Usually,
what important history you will ask about the family?
If there is any family history of nocturnal enuresis,
usually that disappears by 10 to 12 years of age. So you can wait in that case. Okay.
Good example. You can do a focused examination.
Examination, the child is thin built, scar in the right side of the neck and the right upper chest. There's no rickety features in the child, and the height of the child is 158 centimeter. No pallor, no pedal edema, no generalized lymphadenopathy, and BP is 130/90 in sitting position in the right upper limb, and pulse rate is 94 per minute, regular in rhythm and normal volume, and oral cavity is normal, and abdomen is soft. There is right iliac fossa scar present. In the surgical scar, there is wound gaping of around 2 centimeter, and also the scar in the right lumbar region, probably old right nephrectomy scar. And for this child, there is no phimosis and circumcision was not done. And diagnosis, this is donor renal transplantation, post-transplant.
Any other examination did you focus on considering this child?
No rickety features, sir.
Like what did you look for?
This child, we have to look for frontal bossing, ricketic rosary, then cubitus varus, cubitus valgus, genu varum, genu valgum.
Okay.
Short stature. But the child height is 160 centimeter.
Considering PUV, what is the specific finding you will look for in the abdomen?
Thickened bladder, any palpable thick.
Okay, anything else?
Any vesicostomy scar.
What is prune belly syndrome?
Prune belly syndrome, in that syndrome, the baby will have absent abdominal muscle, and the abdomen is very flabby and scaphoid.
Did you see the ureterostomy scar? Was it there? Or ureterostomy is done on the right side.
It's the right side, but
No.
it is overlapped by the right nephrectomy scar. Actually.
No. Right nephrectomy scar must be in the loin. Ureterostomy scar must be in the anterior abdominal wall.
But it is not. It's not there, sir.
Probably the transplanted kidney scar is overlapping.
Why do you think that the child has no rachitic features? Patient is having a chronic tubulointerstitial disease. Why do you think so?
Actually, clinically he's not having, but biochemically maybe he may have.
Maybe because he is having a regular follow-up. You said he was having a 3-monthly follow-up.
Follow-up, yes, ma'am. He's
Was
taking that
soda
calcium
bicarb.
supplements.
He was
yes, ma'am.
adequately taken care of. Probably that is why. Okay.
Okay. So what are the challenges in doing a transplant for somebody who's 15 years old?
The challenges in pediatric transplant is there is mismatch between the donor vessel and the pediatric vessel, ma'am. Because of that, there is difficulty in anastomosis will be there. Then because of this small size of abdomen, the baby might go in for abdomen compartment syndrome. And in pediatrics, when we place the adult kidney, there will be hypoperfusion of that adult kidney.
So what is the complication of that hypoperfusion?
There will be delayed graft function. There is he may go in for ATN, ischemic ATN.
Graft thrombosis also.
Yes, ma'am. There will be more chance of graft vein thrombosis will be there, ma'am.
If the patient is stunted, is there any use of giving growth hormone in this patient?
We can give growth hormone.
So what is the problem in giving growth hormone?
Child may have worsening of hypertension will be there.
Okay. What is the cross-match done in your institution?
We will do CDC cross-match and flow cross-match.
Okay. How is the CDC cross-match done?
CDC cross-match is done by taking the recipient serum and the donor lymphocytes, and these two are mixed, and to which the complement is added. And we will look for the cell lysis. And if it is less than 25%, it is negative. And 5 to 10% is appropriate for transplant.
What is the sensitivity of this test?
Actually, it is sensitivity is around 70%.
So what are the disadvantages of this test?
Actually, disadvantage, non-complement fixing antibody will not be found by this method. And another one is very low antibody titers. If the donor specific antibody is very low, then also it will give false negative.
What is prozone phenomenon?
Prozone phenomenon, if the antibody titer is very high, also it will give negative result. That can be prevented by serial dilution of the sample.
How to improve the sensitivity of this test?
We can improve the sensitivity of this test by doing auto cross match. That will prevent this, that will show if he's having antibodies because of some autoimmune disease, or we can add DTT that will lyse that IgM antibody, and by this also, then only IgG will be present. By doing this also, we can increase the sensitivity of this test.
Okay. What is delayed graft function?
Delayed graft function is defined as need for hemodialysis within the first week of renal transplant, or another one definition is if there is falling serum creatinine of by less than 10% for 3 consecutive days in the first week.
Okay. What do you think is the cause of DGF in this patient?
The cause for DGF can be divided into donor-related factors and recipient-related factors. Donor-related factors can be old age.
In this patient.
In this patient, the donor can be in hypotension, ma'am. Donor is from RTA.
Okay.
Maybe he have some oliguria or anuria, or because of this disease donor, he may have HLA mismatch.
What is the cause of death in this patient, in this donor?
RTA, ma'am. Donor is 14 years and the cause of death is RTA.
Suppose if there is increased intracranial pressure, does it have some effect on the development of DGF?
Yes, ma'am.
Why? How?
Because of raised intracranial pressure, there will be drop in the BP will drop.
Okay, anything else? Very
That
important.
will reduce the that will cause hypoperfusion of the kidneys.
Okay. Then it will release lot of cytokines,
Cytokines.
inflammatory milieu that can also damage the kidney. What about the recipient factor in this patient?
As his child, he may have, as I said earlier, there will be hypoperfusion of the, but the donor is also 14 years.
Prior to the procedure, he would have undergone dialysis. What are the factors in the, what is the modification of the prescription of dialysis on the previous days of transplant?
Fluid removal, we should be cautious, ma'am. We should not remove more fluids, ma'am. Then there should not be any hypotension during the dialysis.
Then what about antihypertensive drugs? What will you advise?
Actually, if we should stop antihypertensives on the day of surgery, ma'am.
Okay. Except probably when
Beta
the patient
blockers.
is on
Beta blockers.
clonidine. That
Clonidine.
can also cause rebound hypertension. Okay. How you can prevent delayed graft function?
Delayed graft function can be prevented by reducing that ischemia time.
What are the different ischemia times?
Warm ischemia time and cold ischemia time. Warm ischemia time in the live patients, it is the clamping of the renal artery and the start.
Name 2 situations where usually the warm ischemia time is not prolonged. Name 2 situations where warm ischemia time is prolonged and it will adversely affect the graft outcome. 2 situations.
In live, ma'am.
Generally.
In general.
When there is vasospasm of the renal artery, there will be delay in starting perfusion, ma'am. That time, warm ischemia time will be prolonged.
Anything else?
When there is 2 arteries, multiple
renal
vessels.
arteries. And donation after
Cardiac death.
cardiac death. Right. Okay. What is the maximum cold ischemia time limit beyond which you will expect DGF?
24 hours, actually.
Okay. So, what is the procedure you will take to prevent DGF? 2 management modalities which are found to be useful. May not be done very commonly in all the centers. Bit expensive also. Can you tell?
Perfusion,
HTK fluid perfusion.
No. HTK, okay. Other than that.
HTK
University
is
of
routinely done.
Wisconsin
Routinely
solution.
done. HTK is routinely done.
Machine perfusion, have you heard
Machine
of?
perfusion is, ma'am.
Okay. Anything else? Experimentally at least? Dopamine in the donor. Prolonged 7 hours dopamine infusion. Some studies have shown that it's found to be beneficial. What is the advantage of machine perfusion, hypothermic machine perfusion?
Actually, it will remove all the clots, ma'am. Because
Okay. Other than the preservation, anything else? Any other advantage? You can decide the quality of the graft by looking at the parameters of perfusion. Perfusion index. You can identify the resistance to flow at 2 hours. All these can be taken. If the resistance is very high, you can discard the organ quality. That can also be assessed. And also you can add some antibiotics, antivirals, and genetic modifiers. All these can be added. These are the added advantages of machine perfusion. Okay. That can be how this child has probably a delayed graft function. And what is the long-term consequence of DGF? Because at the time of discharge, the child creatinine was probably normal. What is the long-term outcome?
by comparing this immediate graft function, the delayed graft function, the graft survival will be poor, ma'am.
Why the graft survival is poor with DGF?
Because of DGF, there will be expression of molecules and child may go in for rejection. One possibility is there, ma'am.
Then, what is the pathology of DGF?
Ischemia reperfusion injury.
That is a pathogen, one of the pathogenic mechanisms. If you do a biopsy, what will you see in DGF?
There will be ATN, ma'am.
ATN. So ATN, what is the long-term consequence of ATN? Is it very benign or a fraction of patients can develop CKD?
It is a continuum. Some patients
Okay,
can go in for CKD.
What is the mechanism of developing a CKD?
Because of this TGF beta, WNT beta catenin pathway is the reason for this, ma'am. In some genetically predisposed individuals can AKM can be continued to CKD by this epigenetic alterations.
There is a maladaptive repair process, then mitochondrial dysfunction, and they can also develop
epithelial mesenchymal transition will be there in this patient.
Right. Many mechanisms are there. These are important. Then how they are predisposed to acute rejection. Sometimes you'll be surprised to see rejection in delayed graft function. Why they are predisposed to acute rejection?
Because of this ischemia and the generation of reactive oxygen species will be there, and that will increase the expression of this MSC molecules and these selectants, ma'am. That will enhance rejection.
Is it cellular rejection or antibody-mediated rejection?
Cellular rejection.
Can antibody-mediated rejection also can occur? It is possible.
If the
It is
patient already
possible.
had DSA, donor-specific antibody,
Yes, not because of DSA. There is an adaptive immunity also getting activated following an innate immunity activation secondary to this DAMP and PAMP molecule released by cell death. So that can also contribute to ABMR. Okay.
What is the long-term outcome for this child? He's now 14 years old. Suppose the parents ask you what will be this longevity of this graft.
if there is no rejection, this graft can survive up to 15 to 20 years. And the
Suppose-
child may need second transplant at later age.
Suppose this patient comes back 1 year later with some proteinuria and a rising creatinine, what will you think?
The reasons can be rejection,
What rejection?
can be ACMR or ABMR, anything can be there.
But after 1 year, which
After
type?
1 year. After he's been very compliant with medications.
If he's complained, then ACMR is.
If he's compliant, why should he have ACMR? Let's say somebody who's meticulously following drugs still has developed some proteinuria, hypertension, and some worsening creatinine after a few years.
It can be due to chronic allograft nephropathy.
Chronic allograft injury. What is it due to?
Chronic allograft injury is due to it's chronic inflammatory process that one is going on.
What else can develop in somebody who's undergone a transplant? chronic allograft nephropathies, if you do a biopsy, what will it show?
It will show transplant glomerulopathy picture. There will be multi-layering of the
Right.
glomerular basement membrane.
That's-
there will be
that's after some
glomerulosclerosis,
time.
interstitial
That's after some
atrophy.
time. A little earlier than that.
Arterial hyalinosis will be there.
Okay, let me ask you, what is the common cause of long-term graft dysfunction?
Long-term cause of graft dysfunction.
If you have a ABMR, what is the cause of that ABMR?
If the patient is drug incompliant,
Right.
if the drug is inadequate dosing, or if there is donor-specific antibody, patient
Right.
can develop go in for ABMR.
Right. So some other antibody can develop in somebody who's having a chronic graft dysfunction.
Non-HLA antibodies,
These DSAs can be classified as what?
donor-specific antibodies and non-donor-specific antibodies.
Right. Could you classify it better, like de novo antibody?
De novo, one is pre-existing, another one is de novo.
De novo antibody.
Pre-existing before the
That
transplant.
happens acutely, yeah. So what happens in the long term?
Long-term, patient can develop de novo antibodies.
Right. So what are the causes of development of these de novo antibodies?
The patient is drug incompliant.
What do you do with the CNI? Let's say put 3-4 years down the line, the graft function is stable. You try to reduce the
The CNI.
CNI. So,
Can keep up 4 to 5
right,
nanogram.
so this reduction of CNI is known to predispose to these de novo antibodies, right? Okay. So what would you do in such a situation?
We can hike the immunosuppression, sir.
Okay. Anything else?
The
Yeah,
pa-
optimization of
Immunosuppression.
immunosuppression.
If the patient is on steroid-free regimen, we can add steroid.
Right.
If the patient is on cyclosporin, we can change to tacrolimus.
Okay.
If the patient is on AZA, we can change to MMF. Like that, we can do, sir.
Okay. This is one. Anything else you can do? Any other drug that has been found to be useful?
In
Chronic
the-
ABMR.
that in IL-6 antibodies can be
Okay,
given.
tocilizumab. Okay. Clazakizumab. Okay. Fine.
Any role for complement-based therapeutics in prevention of DGF? At least experimentally.
No idea. Don't know, ma'am.
Okay, coming back to his bladder. This bladder is a real problem in patients with PUV,
Yes, ma'am.
especially when they undergo transplant. So patient will be mostly oligoanuric while on dialysis. So in such situation, how do you assess the bladder? There is no urine output. You want to know whether you can use that bladder usefully. What should be the bladder like post-transplant? What is the aim?
Post-transplant bladder should have good compliance and the filling pressure will be low, should be low, ma'am. Otherwise, there will be reflex will be there. We can assess that by doing uroflowmetry or urodynamics.
That's what madam is telling. There's no urine.
Urine
So
output is
how
there,
to
we
assess
can do
the bladder?
uroflow dynamics.
3 C's, compliance, continence and
One more.
capacity.
Capacity.
3 C's. Okay.
This patient had induction therapy. So what is the KDIGO take on induction therapy?
KDIGO advise induction for all transplants. If there is high risk, it advise ATG based induction, and if it is low risk, it advise basiliximab based induction.
You mentioned this patient is on Valgan prophylaxis. What are the types of prophylaxis that you know of?
Valgan prophylaxis can be, it can be universal prophylaxis. Immediately after transplant we can start, or it can be preemptive prophylaxis. We can weekly, we can see the CME DNA PCR level, and if it is start to rise, that time we can start Valgan prophylaxis. These are the two types.
Okay. Any evidence for this?
Evidence,
Any studies?
don't know, sir.
Name one advantage and one disadvantage of each type of.
Actually, that preemptive will reduce the cost of that, then
Cost?
cost of the tablet cost. Preemptive prophylaxis. In that universal prophylaxis, it will prevent the CMV infection, but late infection can occur with this universal prophylaxis. If we stop treat prophylaxis at 3 months, at 6 months, the child may get CMV infection.
It's a disadvantage.
Ma'am?
Disadvantage of preemptive.
What are the uses of cotrimoxazole, trimethoprim prophylaxis? Why do you give that?
One is mainly to prevent Pneumocystis cerevisiae infection, and another one is it will reduce the instance of UTI, nocardia, then toxoplasma post-transplant.
What happens to CKD MBD after transplant? When do things normalize?
It will take 3 to 6 months to normalize.
May take up to a year. Okay. So in this patient on whom you're going to be on steroids, is there any role for giving alendronate, bisphosphonates to prevent osteoporosis?
We can give that, but
if you are prescribing alendronate, how will you prescribe? What instruction will you give to the patient?
the patient should take in empty stomach. Then the patient should be in upright position after taking tablet for 1 hour.
Right. Okay.
What is the target level of bicarbonate in patients with CKD?
As per KDIGO, it is 22, ma'am, not more than the normal. And we should start treatment if it is less than 12, we have to start treatment, and it should not be more than normal range.
Suppose if it shoots beyond the upper limit of normal, what are the complications you expect?
Child can have worsening of hypocalcemia will be there, ma'am.
Cardiac failure. Cardiac failure is common. Okay. You have asked now, bicarbonate. You have already asked.
Yeah.
Okay.
Is there any family history in this patient?
No, sir, no family history of CKD.
Can you
Renal
tell us
disease.
briefly about how the kidney develops?
Actually, kidney, there will be develops from mesoderm. There is 3 mesodermal derivatives. One is pronephron, mesonephron, and metanephron. Pronephron and mesonephron will degenerate, and kidneys, nephrons develop from that metanephron, and they develop, and that ureteric bud will come from this urogenital sinus, and the ureteric bud should reach that metanephron for the proliferation of the nephron. And many factors are responsible, like PAX, then GDNF, like factors, they are responsible for the nephrogenesis. And the nephrogenesis starts by around 4 weeks, and it completed at around 36 weeks.
So when does the urine formation start?
Around 6 to 8 weeks, urine starts to form.
And when is nephrogenesis completed?
By 36 weeks, it will be completed. In preterm baby, post-delivery, there will be some nephrogenesis.
When does the creatinine come back to adult level?
In
Creatinine.
newborn,
When does it come to the normal adult?
newborn babies, when by 1 week it will reach that normal level.
1 week is too early. No?
What is the creatinine of the newborn baby?
Actually, it will be around 1.
Why it's 1?
Because of this maternal creat will be in the
Right.
fetus. Because
So
of that, it will
itself
be
will
high.
take about 10 days to normalize.
What is copum?
COPUM. It's a name for another common disease that you discuss. Anybody else? Hi, yes, sir.
Yes, sir. Post-transplant. Post-transplant, he was started on NTG and labetalol infusion. Beta blocker itself will worsen hyperkalemia. And metoprolol. Propranolol, okay. Second dialysis.
Thank you. One very important issue is anemia. A patient of chronic kidney disease, he or she may not have the symptoms because of anemia. But as you correct acidosis, what happens is, this patient, acidosis usually shifts oxygen dissociation curve to the right. And we have time and again seen that when dialyze the patient, before dialysis, the anemia was well tolerated. You dialyze the patient, say suppose hemoglobin was 5, and immediately after dialysis, the patient becomes dysfunction. That is very important issue other than whatever Madam has said. Sorry, I just...
No, welcome, sir. Okay, you did well. You have to be a little slow while presenting. And you mentioned there was no generalized lymphadenopathy. Why did you mention that? Was there any relevance to this patient? Or did you think of some lymphoma or something? No. Yeah. So at a DM level, your examination should be more focused. And we need not mention neurocutaneous markers or lymphadenopathy or clubbing in every patient. Right.
Thank you, sir.
Right.
Thank you.
Thank you. Thank
You did well. You have to concentrate on the bladder. Transplantation in abnormal bladder also you have to concentrate upon. Presented well otherwise.
Thank you.
Thank you, sir. Thank you, ma'am. Thank you, Dr. Kirtika.